Consistency, validation, position, consistency, effacement,
Stationation of internet. Validation effacement. Instead of effacement, na, that is Bishop score. In modified Bishop score, instead of effacement, there is survival effacement. Okay. And the last year about it. Okay. In which Bishop score you go for induction of labor, in which Bishop score you go for augmentation of labor.
above we go for induction, above 9.
Above 9, induction, augmentation. Below 5 or 6, you go for induction of labor. If you get any drug, you should start it as, so what is it, drug, which group it belongs to, what is the mechanism of action, what is the T-half, what is the duration of action, what are the uses, what are the side effects, what are the advantages and what are the disadvantages, and what are the contraindications. Okay, in these headings you should tell all the drugs. Okay, and this is dinoprostone used for induction of labor. What are the side effects? Hyperstimulation, tachysystole, fetal distress. Then what are the other methods of induction? This is one method of induction. What are the methods of induction we have? Medical and mechanical methods. Mechanical methods and medical methods. In medical method, one is dinoprostone, other is misoprostol. What it is? PG, even analog. Okay. Misoprostol is PG, even analog. Mechanism of action, uterine contraction. How it differs from oxytocin? It causes both upper and lower segment contraction. Whereas oxytocin causes upper segment contraction and lower segment relaxation. Okay. Then this is PG1 analog. What are the routes it has to be given? Sublingual, oral, parectal, vaginal. What are the uses? And there is different duration of action when you give it in different routes. You should know about it. Okay. What are the uses? Abortion, induction, PPH. PPH as a prophylaxis and treatment. What is the dose in prophylaxis? What is the dose in treatment?
10 years.
600 in prophylaxis. 800 in treatment. Okay. This is available only as tablet form. Okay. And what are the side effects? Side effects. Hyperthermia. Okay. It can cause fever. Okay. Then gastric discomfort. Then it can cause both upper and lower uterine segment contraction. If you use for induction of labor, it may cause fetal distress and tetanic uterine contractions. Okay. Then other method of induction. Inductions, mechanical method, Foley's catheterization, then membrane stripping, artificial rupture of membrane is a method of augmentation. Okay, then Foley's then membrane sweeping or membrane stretching, and then sexual intercourse. These are the natural methods of induction. Okay? What is it? Pap smear. It has
Cytobrush.
Cytobrush. Then eye spatula. Eye spatula. This is eye spatula. Okay? In eye spatula, we use it to take cervical sample through this. It is a use of it. Then takes me into what? After history. Okay. How many times you rotate it? If you get pap smear, everything Viva will go towards CA cervix screening. Okay. It will go towards CA cervix screening. What you will do? How many rotations you do to this?
360, two rotations.
360 degree? No, one time. Only one time. With the cytobrush, how many rotations? That is only half rotation, that is 180 degrees. Why? If you do it continuously, there will be disruption of cells. That's why we do it. And what is the prerequisite? PAPs? Okay. PS or PVR? PS should be done to visualize the service. And then PV should not be done, and there should be no intercourse for 24 hours. There should be no vaginal bulging for 1 week. There should be no bleeding, no vaginal discharge. No, there should not be any infectious discharge. Okay, these are the principles that should be met and it should be taken. And have you heard of liquid-based psychology? What it is?
Just to find out which.
What is the difference between liquid-based? Do you know what is liquid-based psychology? Yes. Same. That is one advantage. Then, what is the advantage of it? Inadequacy of this specimen, inadequacy of this smear is reduced. Then, and that can be done even when bleeding is there. And even if bleeding and discharge is there, we can do LBs. And we can detect HPV DNA also in liquid-based cytology, not through PAPs. Then, is there any difference between sensitivity and specificity between the two? How many are saying yes? How many are saying no? Yes, there is no difference between sensitivity and specificity between the two. Okay? Only the adequacy of specimen is improved with liquid-based cytology. Okay, done? And at what age we start screening for cervical cancer? According to ACOG. According to WHO, 30 years. 32, 39 years. It is 30 or 35 years you just confirm, okay? And if you do LBC and HPV DNA, how frequently you repeat the test? 5 years. If you do with the PAPs, 3 years. Very good. Then what it is? Okay, it will look like this, okay? This is Carmen's cannula, okay? If this Carmen's cannula comes, your vulva will go towards suction and evacuation, okay? What are the uses of it? How to select the size of it? What are the advantages? What are the disadvantages? How to select the size of the Carmen's cannula? Okay, if it is 10 weeks of gestation, what is the size you select? 10 or less than 1 size, that is 9 you select, okay? Then while this is used for suction and evacuation, okay? While doing suction and evacuation, how you will get to know that the procedure is complete. There is no retail products inside the uterus. Then gripping sensation, then air bubbles, then decreasing bleeding. These are the 4 signs you should remember. Okay. Then what are the other methods of suction and evacuation? Manual vacuum aspiration. That is not there, but they can also ask that also. What is the advantage of manual vacuum aspiration over the suction and evacuation? Very good. Okay, that is one of the advantages. What is the capacity of the 10 ml syringe? 60 ml or 600 ml? What is the capacity? You will find out what is the capacity, okay? Then Foley's catheter and Urobag is one surgery only. Do you know the color code? What is the size depending on the color code?
16
Green
French.
is how much? Green is how much? Green, orange, red. In the frequency, in the sequence it comes. You should know the size, okay? What is it? Low molecular weight balance. Okay, if this comes, your vulva will go towards thromboprophylaxis, heart disease, APLA. Okay. If this comes, they'll ask you about difference between this and manufacturing repellent. Okay, what is this low molecular weight repellent? It is an anticoagulant and it inhibits which clotting factors I forgot it. You should find out what are those clotting factors it is inhibiting. Then, what are the uses or indications where we will use in pregnant women? Heart disease post-delivery as a prophylaxis. There are some scores. Depending on the scores, if it is high risk, we can use post-operatively. And in gynae cases also, in gynae onco cases also, post-operatively we give low molecular weight heparin to prevent thrombosis. Okay, these are the indications. What are the contraindications? It is a blood thinner. So what are the contraindications?
Bleeding.
Bleeding disorders, low platelet count. How much? Less than 75,000. Okay. Low platelet count, bleeding disorders, then severe delays renal and liver function. Because excretion of this drug happens through the thyroid, and then recent history of IHB, recent history of stroke. Okay. Then bleeding tendencies, if in the case of placenta or antepartum hemorrhage, we don't know this. Okay. These are the indications and contraindications. What is the mechanism of action? It inhibits which clotting factors in the you find out. Okay. Then what is the T-half? T-half. By this you will get to know the difference between unfractionated heparin and low molecular weight heparin. T-half of unfractionated heparin is 4 to 6 hours. Low molecular weight is 16 to 18 hours. So the frequency is less for low molecular weight heparin. Which is better, low molecular weight heparin or unfractionated heparin? Why? Very good. Then osteoporosis, that will also be unfractionated heparin, and the action of unfractionated heparin is unpredictable. But low molecular weight heparin action is predictable, and you need frequent monitoring with unfractionated heparin. No need of frequent monitoring with low molecular weight heparin. How do you monitor when patient is on unfractionated heparin? No, it's FATT. INR you monitor when patient is on warfarin. Okay. Then if she is on low molecular weight heparin, obviously there is no need of continuous monitoring. If patient is of extremes of weight, if she is very low weight, if she is very obese, or if she is having liver or renal derangement, then we can go to monitor. What you monitor? Factor 10A levels. Okay, this is the difference between these two. Then what else? Then done with low molecular weight heparin. Indications, contraindications, advantages, disadvantages. And in low molecular weight heparin, what are the drugs we have? Enoxaparin, dalteparin, then one more is that. Okay, this is paxlovid. Then we'll come to ubrotonics. Oxytocin. Can somebody tell me about this drug? Huh? Oxytocin. Examiner will give you like this. It's a natural, huh? Oxytocin is progesterone.
From posted. Posted.
You should tell her. Also, you can mention flavor. Augmentation of flavor.
Augmentation.
It is an oxytocin. What is it? It is an octapeptide, synthetic oxytocin analog, which is octapeptide. Whereas natural oxytocin is non-peptide, which is separated from. It is stored in pure posterior pituitary. Segregated from which nucleus? Supraoptic or paraventricular? Paraventricular. Stored in posterior pituitary. The similar way, similar to oxytocin, this is a synthetic analog. What is the mechanism of action of oxytocin? PG? Who said PG? It is doing something with the calcium channel. When the oxytocin binds to oxytocin receptors in the uterus, then what it will do?
Calcium is released from
Increases the intracellular calcium level and it causes contraction. It causes upper segment contraction, lower segment relaxation. That's why polarity of the uterus is maintained. Okay, that's why it will not lead to fetal distress. Fetal blood circulation is maintained. That is one major thing with the oxytocin where other lipotonics cannot do that. Misoprostol cannot do that, and methyl ergometrin also cannot do that. Only oxytocin can do it. Okay, then and intermittent relaxation between it. What is the T of oxytocin? T half 3 to 5 minutes. What is the duration of action? When you give it higher, when you give it IV, there is a different duration of action. When you give IV, it starts acting immediately till 1 hour. When you give IM, 3 to 5 minutes till 2 to 3 hours. Okay, it will act. That is duration of action of oxytocin. Then what are the uses? Tell me, augmentation, active management of third stage of labor, then pH management. Okay, these are the main uses. Then what are the side effects? Water intoxication, hypotension. Sometimes. Okay. Have you heard of carbetocin? Acha, have you preserved this oxytocin? At what degree Celsius? At 8 degrees Celsius in the refrigerator. Shoulders? Acha, that is one of the complications. Okay. Then what are the other side effects? Acha, I was asking you about carbetocin. What is carbetocin? Okay. Difference between carbetocin and oxytocin? Very good. Then other uses. See, one more thing is carbetocin is not widely available. It is costly. Okay. Then carbetocin doesn't need any requirement of refrigeration. Okay. But carbetocin cannot be used when baby is inside. It is not used for augmentation, only used for PPH management. Okay. Then what are the other uterotonics used in PPH? Misoprostol we already discussed. Then methyl ergometrin, carbopros. Is there any difference between oxytocin and Jumbo? I'm asking you an actual. There is no difference between oxytocin and Jumbo. Okay. Who will tell me about carbopros? What is it? PGF2 alpha. What is the dose? 250 micrograms. Given root intramuscular. How many doses we can give? 8 doses maximum. What are the complications? Side effects. That is a complication and contraindication also. Bronchial asthma is a contraindication. What are the side effects? Diarrhea. Bradycardia. Sometimes, but not always. Diarrhea is most common, okay? Okay, you will tell me about methogen. What is methogen? It is an alcohol derivative. Okay, what is the mechanism of action? Lower segment of the uterus. That's why it is not used for induction or augmentation. It is used only for PPH management. Okay, what is the dose? 0.25 mg. Root IM. How many doses you can give? 3 to 4, not 5. Okay. Then what are the contraindications for methyl ergometrin? Eclampsia. Organic heart disease. She told already. Okay. Then, have you heard about symptometry? Methyl ergometrin. Dose? 0.5 mg of methyl ergometrin. We have both oxytocin, we have both oxytocin and methogen. Can we prepare it in labor room? Why? It is a fixed drug combination. It is available combined only. Even if you have both the drugs, we cannot combine them. Okay? Okay, we are done with the uterotonics. And what is the main advantage, main use of oxytocin? You do not open your mouth only. Unnecessarily I made you your hand up. Okay. Active management of third stage of labor. What are the 4 components? 4 components of AMDSS. Huh? Injection of petrochemical. What is the petrochemical? 10 units. IM or? IM or? IV. Bolus.
Slow.
Gyno bolus. IV infusion.
Infusion. Slow infusion.
Oxytocin. Other one? 1 to 3 minutes. Then contraction. Then intermittent interval assessment. So how long after delivery? For about 15 minutes to 2 hours. Okay? We are done with the oxytocin also. This one you will only tell me.
Iron supplementation. Iron and folic acid. IFA.
If this comes, they'll ask you everything about anemia Mukti Bharat. Okay? What is iron plus initiative? What are the 6 components of anemia Mukti Bharat? Beneficiaries means age group only. 6 interventions and then 6 institutions. What are those 6 age groups? 6 institutions. What are those 6 age? 6 to 59 years done. 5 to 9 years. To 6 to 59 months we give iron syrup. To 5 to 9 years we give painkiller tablets. Then 10 to 19 years adolescent boys and girls we give blue color tablet. Then women in reproductive age, women in pregnancy and women in lactation. For women in reproductive age, weekly 1 tablet of iron and folic acid, red color pill, and women in pregnancy and lactation, 6 months, that is 180 days before the delivery and 180 days after the delivery. Prophylactically, we give only 1 tablet. Under the Government of India, it is ferrous sulfate, where 100 mg of iron tablet containing 60 mg of elemental iron and 500 micrograms of folic acid. Okay, but whereas different iron formulations are there, oral iron preparations, one is ferrous sulfate, one is ferrous fumarate, then ferrous ascorbate. This oro for XTR is ferrous ascorbate. This ascorbate is more elemental iron. Okay, and then ferrous fumarate. Ferrous fumarate has 200 mg, has 60 mg of elemental iron. What is the difference between these salts? Ferrous sulfate, fumarate, ascorbate. One I told, that is elemental iron is different. And then one more is that absorption will be different. One more important thing. Ferrous sulfate has tendency to cause gastric disturbance. And the patient has gastric disturbance, she comes with having ferrous sulfate. We can change the iron preparation. Okay. And you should also know about parenteral iron preparations. What are those parenteral iron preparations? Iron dextran is given nowadays. Ferrous carboxyl maltose and then iron sucrose. Iron sucrose is 2nd generation. Ferrous carboxyl maltose is 3rd generation. Okay, and you should know the metabolism of iron in the body. Okay, where is the maximum part of iron is absorbed in our blood? Duodenum. Very good. Okay, then 6 interventions of anemia Bharat. Iron folic acid tablets, then quantification, then that is one of the among continuous medical education it will come regarding complaints of iron tablet. We should explain them the complaints of iron folic acid supplementation, explain the importance of deworming to them. Then
24 minutes.
one more, to detect the other causes of anemia other than iron deficiency anemia, like thalassemia, fluorosis, malaria. Okay. These are the 6 interventions. We are done with the folic acid, iron sulfate. Do you have any doubt? What is iron plus initiative? We'll find out. Magnesium sulfate is also there. Okay, magnesium sulfate. What it is?
Neuroprotective drug.
I told you to start with those headaches now. What it is? What is the mechanism of action, duration of action, uses, dose. What is the mechanism of action of magnesium sulfate? Calcium channel blocker, membrane stabilizer, glutamate inhibitor, GABA, adenosine and GABA enhances the action of adenosine and GABA. Okay, this is the mechanism of action. Uses in obstetrics and gynecology. Three main uses.
Eclampsia.
Then
Tocolytic.
preterm delivery.
Mild.
As, for neuroprotection. Then as a tocolytic.
Tocolytic.
Okay, you should know what is the dose, especially the Pritchard regimen. Everybody should know the Pritchard regimen. Okay, you tell me about Pritchard regimen.
14 grams overall.
Directly will be 5 grams each.
4 grams 4 grams 20%
Dose
IV.
4 grams 20%
IV.
15 to 20 minutes.
Slow infusion.
That is 15 to 20 minutes. Okay, if you give 3 to 5 minutes, what will happen?
ಇದು
As you go 3 to 5 minutes, I'm asking the question. Like this only 15% will do. So you should not be saying what is your what you use. If you give him 3 to 5 minutes,
Gratting?
what will happen?
No, something.
Exactly. Hypothermia, flushing.
Hypothermia,
Patient will not
flushing.
be able to tolerate it. She'll be having nausea, vomiting. Okay, that's why it should not be given 15 to 20 minutes. And then loading dose consists of 4 grams of IV and 10 grams of IM. In 10 grams of IM divided into 5 grams, 50%. IM is always 50%, IV is always 20%.
20%.
Okay, give 50%, 5 gram IM in each bottle. Okay, maintenance dose repeated after
Alternate 4 hours.
Okay, 5 grams.
Alternative
50%,
buttocks.
alternate
Alternative
buttons.
buttons.
Before giving maintenance dose, what you said? Dependence flex.
DTNR.
Urine output. Urine output should be more than 30 ml per hour. Respiratory rate should be more than 16 cycles per minute. And if urine output is less, what you do? You just skip the dose of magnesium sulfate. If respiratory rate is less and if you are finding dependent reflexes are also not there, then you will sign for magnesium levels. This is Pritchard regimen. Okay. Then what is Uspan regimen? It is an IV regimen. You know, 4 gram 20% IV over 15 to 20 minutes, followed by 1 gram 20% IV infusion per hour. Okay, that is Uspan regimen. In clinical, which one is better? Why? We give, that's why it is better. And you remembered it, that's why it's better. Now it is better.
Manageable.
Now it is better. You're not well. You have water, no? You drink water. No. See, when you give IM, the magnesium sulfate action is unpredictable when you give intramuscular. When you give IV, you can monitor the action and the duration of action differs. When you give IV, the duration of action starts immediately till 1 hour, and if you give IM, the duration of action can continue to 3 to 4 hours. If there is any toxicity, if there are any signs of toxicity, you can stop the IV infusion immediately. But you have given already the IM dose, you cannot do anything with the IM dose. That's why IV is better. Okay, but why we are not practicing IV? Still it is better. Because in India, as it is a resource limited country, we need, if we are giving IV, I said 1 gram per hour infusion, that should be monitored properly. For that, we need infusion pump and all. In our wards, there is no facility of infusion pump. That's why we don't go for Zuspan regimen. Okay? And other uses tocolytic, other uses neuroprotection. Okay. And what is the antidote? If there is magnesium toxicity.
Calcium gluconate.
Calcium gluconate. Dose percentage over within 10 minutes. Okay. This is regarding magnesium sulfate. And you should know what is the therapeutic level of magnesium sulfate. 4 to 7 milli equivalents. There are different values in millimoles, milligrams, and milli equivalents. You remember only one value. 4 to 7. Okay, milli equivalents. Absence of knee jerk happens at more than 7 milli equivalents. Okay, and respiratory depression occurs more than 12. Respiratory paralysis happens more than 15. And cardiac arrest happens more than 25. Okay, more than 25 milli equivalents. More than 24 milli equivalents, cardiac arrest will happen. This is magnesium sulfate. What is this? Labetalol. What is it? Alpha plus beta blocker. Alpha selective or beta selective? What? Where you have read it? Alpha selective or beta selective?
It's like alpha plus beta. Selective.
I think it is alpha selective, beta non-specific. Okay. What is the use? Antihypertensive. Dose?
20, 40, 80, 80, 80.
Total? 300 mg. That is IV dose. Oral dose? No. 100 mg PID you can start. You can give up to maximum of 2400 mg per orally per day. That is the maximum dose of labetalol. Okay, what are the other antihypertensives used in pregnancy? Nifedipine, hydrolazine, then nitroglycerin, then
Dobutamine.
no. Who said dobutamine is antihypertensive?
Sorry.
Then methyl dopa. Have you heard of it? Centrally active.
Dopa.
But it has a
Methyl
long
dopa.
it has to start its action. It takes a long time. That's why we cannot use it in preeclampsia or hypertension emergency. It is used only in chronic hypertension. Okay. This is labetalol IV oral. What are the side effects of this drug? Side effects. Bradycardia. What are the contraindications? Asthma, heart failure. Okay, these are the contraindications of labetalol. Okay. Other antihypertensive you should know. Like they can also keep them. And some betamethasone and dexamethasone was there. This is betamethasone. What it is?
Corticosteroids.
Corticosteroid. What is the use? Achha, okay. I was telling you about magnesium sulfate now. We told it can be used for neuroprotection. There is a mechanism of action in neuroprotection. Then
So blocks the
anti-inflammatory. Then vasodilator. As it dilates the vessels, blood supply to the brain will be maintained. Okay. And at what gestation and all it should be given, it is not necessary. Then what is betamethasone? Corticosteroid. What is the use? What are the advantages other than lung maturity? Other than lung maturity? Prevents NEC, then intraventricular hemorrhage, prevents NICU admission. Then when you give this corticosteroid to a mother, before 34 weeks you should give. Why before 34 weeks? There is a reason for every symptom. Stomach is mature by the time. That's why you should give before that. There is another corticosteroid called dexamethasone. What is the difference between betamethasone and dexamethasone in terms of dose?
mineralocorticoid predominant.
You know about it. Okay. Okay, what are other differences? There is some difference in components also. You'll find out about it. Okay. Other than that, there is no major difference. What are the side effects to the mother?
Immunocompromised.
What are the side effects of steroids?
Immunocompromised.
Increase blood sugars. surgery. Is it? Then it's not my job to teach you sutures also. You ask surgery to teach you, okay? You want contraception or sutures? Sutures surgery people can tell you. Okay. What are the methods of contraception? Natural.
Barrier. IUCD.
We have permanent and temporary method. In temporary we have natural, barrier, hormonal, devices. Okay.
Last.
Natural, what are the natural methods of contraception? Lactation and amenorrhea. Which is the most effective natural method of contraception?
Common.
Lactation and amenorrhea. Then coitus interruptus. Then Canada method. Then have you heard of Tirumala method? Beads. Standard age method. Standard age method is also there. Then cervical mucus method. Billings method. Then
Spin bar के
temperature
test
monitor.
लो refer have.
These are the natural methods. Among barrier methods we have under the government of India, male condom available in the name of Nilos. Is female condom available in government of India, like under the government of India? Family planning program is it available? No. So what is the difference between, how do you differentiate between male and female condom? Female condom has 2 rings. Male condom has only
One
1
ring.
ring. What is the other advantage of this barrier method of contraception? Prevents sexually transmitted diseases. That is one of the main advantages. What are the disadvantages? Disadvantages. Failure. Like failure of
4%.
complaint should be there. Okay? And this is barrier methods. And what are the other barrier methods of contraception? Diaphragm, sponge, spermicidal gels. But those are not that much effective. Okay? Among the diaphragm can be used for 1 year. Female condom can be used twice. Can male condom be used? No. Then in barrier method is over. Hormonal method. You had hormonal method. In hormonal method we have combined oral contraceptive pills, then
ENP.
emergency contraceptives, progesterone only pills. In combined oral contraceptive pills under the government of India, which tablet is available? Mala D.
Malaya.
What is the difference between the two? It's not like that. Mala D is 1 rupees, Mala N for no cost. Mala N is free, that's it. Okay. And what is the composition of this Mala N or Mala D? Okay. 159 grams. Okay. You should know the generation of progesterone also. According to the generation of progesterone, Mala N comes in which generation? Second generation. Second generation along with levonorgestrel, what are the tablets? You said testosterone. Levonorgestrel, norgestrel. Remove levo from it. That's it. That's in second generation. Third generation is testosterone, gestodone, norgestrel. Fourth generation, prosperinone, dymogest. First generation, norethindrone, medroxyprogesterone, acid. Okay? These are the generations. Have you advised them when I take this tablet? She should take from day 2 of the cycle. She should take continuously the 21 days, and then 7 tablets will be there. She should complete that, and again immediately the next day she should take the new packet. Okay? Even if she is not having withdrawal relief, she should continue the tablet. What if she misses 1 tablet, 1 or 2 tablets? She should take the tablet immediately then.
If she misses more than 2 or more than that, then she has to start it again from first. 1 tablet is okay.
What she should start once again? She should close this tablet then.
Consecutive.
Within first 2 weeks or the third week. If it is within first 2 weeks, she should take the forgotten pill immediately whenever she remembers, and she can continue the rest of the pills, but she should use alternate method of contraception for 1 week. If she had partners in the last 72 hours, she should use emergency contraception also. If she missed more than 2 pills in the third week, as I told, she should remember, she should take the tablet whenever she remembers, she can continue the tablet, but the thing is that she should discard the 7 non-hormonal iron tablets. She should discard those tablets and she should start from the new kind. And she should use barrier contraception and emergency contraception if she had partners.